So the patella is a sesamoid bone, and Vesalius said that the sesamoid bone is the repository of the soul after death. And I can tell you, when you're dealing with damaged extensor mechanisms, my soul dies by degree every single time I face a case. So this is, I think, the most complex thing that I face in revision knee surgery. We're going to cover 6 aspects: the patella, whether to replace or revise, post-patelectomy patients, fractures, tendon ruptures, quads ruptures, and salvage. So the patella in revision, 2 questions: to replace or not, or to revise or not. So for me, whether if I replace the revision, it depends on preoperative symptoms, my own personal beliefs. And what I tend to do in a first-time revision, I preserve the patella whenever I can. In a re-revision, a bit more complex, a bit more soft tissue damage, then I would have a lower threshold for changing it. When there's already a patella in place, again, is it symptomatic before I start? Is it loose? Is it infected? Commonly, we see a lateral facet, a hook osteophyte that captures the patella and drags it laterally. So very commonly for me, if I'm leaving the patella alone, I'm removing that lateral facet and making it run a bit better. But whatever your decision is with the patella, decide early in the revision. If you're 2 hours into a difficult case and right at the end, you've got to think about what to do with the patella, your decision making is not good. So my advice is decide what you can do with the patella on the way in. Even if you leave it till the end, make an early decision, then stick to it. Here's an example: overstuffed femur. Just revised the components, left the patella alone. It tracks nicely. We've taken away the overstuffing. Pain goes. Infected re-revision. It's clearly loose, so we revise everything. And that's an absolute indication in my books, the infected case. Post-patelectomy patient. In fact, I had a phone call while waiting to come on from an old fellow asking me, do you need to put a hinge in when you have a post-patelectomy patient? And I think you need to decide on merits of the joint itself. I personally wouldn't unless there was another reason. So with patelectomy patients, if it's a good patelectomy, it's functional, it's tracking centrally, you can happily ignore it. If, as sometimes happens, the patelectomy dissipates and thins and slides over the condyles, then you can do an insult tube procedure. You bring the edges together, form a central tube that tracks up and down the middle, and use it as a soft tissue reconstruction. We've also got porous grafts, allograft and autograft. And I, like most surgeons, would have tried these trabecular metal augments on patelectomy patients. I've done 2, and 2 have failed. You need bone to get integration with these augments. So you can stitch it into the fibrous tissue of the patelectomy. It won't work. So avoid this. If you want to do a allograft, then what I tend to do is use a tender Achilles allograft. It's much harder for me to get a full extensor mechanism allograft in my unit, but we can get tender Achilles relatively easily. So we reconstruct using a trapdoor principle, bone block into the proximal tibia, covered by an anterior shelf of bone, and then we stitch up into the quads mechanism and then close it and tension and extension. They will always get their bend, but don't tension and flexion. And then there's autograft, a case similar to one we discussed at the start of the afternoon, 30-year-old trauma, greater than 30 degrees deformity in the femur. And we did a 1-stage revision, osteotomy, sleeve and stem through, and then we've reconstructed the patella using the medial femoral condyle. So because it's a primary, we take the medial cut, it's the right size and dimension, make a little pouch into the patelectomy tendon and stitch it in. And there's the 2-year follow-up where the patelectomy revascularized and working well as a lever arm for your extensors. Patella fractures, management depends largely on extensor integrity and where there's an implant in there and if that implant is well fixed. So if your extensors are intact, leave it alone. Close treatment, immobilize, let it heal. Do not go looking for trouble. If you have extensor disruption, displaced, horizontal, surely these need internal fixation. I used to think so, but this case came to me 5 months after the fall, full extensor function, fibrous union, and I've left it alone and it's done very, very well. What also colours my influence is that if you go in to fix these fractures in the presence of implants, you have a very high infection rate. So these fractures are susceptible to post-operative infections. So try and avoid, unless absolutely necessary, internal fixation of the patella. Only if you think you cannot manage conservatively, operate on them. Next is patella tendon ruptures. These can happen intraoperatively or postoperatively. Intraoperatively, it's generally the well-meaning assistant aggressively retracting the patella. So be very careful. If your assistant's working for you, make sure the retractor's at the level of the patella, not below, so it's not tensioning the tendon. Post-op, it happens with traumatic forced flexion, and there's an acute loss of extension. Sometimes it's iatrogenic, and Aaron Mlaji showed some lovely cases of displaced spaces, and here's an example. I've seen 4 or 5 of these where a disc of cement has just taken out the extensors, and that's a difficult problem to resolve. What you do, if it happens on table, repair acutely, either using hamstrings or supplement with wires. In a chronic situation, you can reconstruct using hamstrings, gastroc flap, extensor allograft, and mesh. And here's an example of a rupture repaired with an overlapping tender Achilles allograft. Similar but different, quads ruptures. Again, post-traumatic, forced flexion. If it happens acutely, fix it acutely. These are not ones to treat conservatively. If it happens late, you need to think about significant reconstruction protocols. So acute early, take to theatre within a few days, suture, immobilize, let it settle. Chronic, as in this case where there's a chronic patellar bar after multiple revisions, you need to think about a more significant intervention like a gastroc flap, an allograft, or a mesh, or a combination. Medial gastroc flaps, very well an effective method when you're dealing with primary tumor surgery, and you can mobilize the extensor mechanism and stitch it back down on the implant. When you're dealing with chronic reconstruction, chronic failure, it's nowhere near as good as in the acute phase with tumor implants. If you're going to do it, it has to be pedicled, so it joins the top and bottom. Probably more effective is a full extensor allograft, and I have limited experience with this, but my colleague, Professor Baldini from Florence, has probably the largest series going in Europe, and his results are very impressive. I struggle to match them. Here's a case where we had to do a full re-revision. We did an extensor allograft and covered the allograft with a medial gastroc flap, all in one sitting, so we have soft tissue vascularized coverage over the allograft after the revision. And lastly, salvage. A colleague of mine did a complex primary. The patient fell post-op and took out the full extensor mechanism. It's infected, we have no patella, we have no tendon, it's an elderly patient, and this for me is a salvage scenario. So we undertook a single-stage arthrodesis using a long nail. We use a vacuum pump to treat the soft tissue defect, and that's the wound at 6 weeks. And a 9-month review, fully united, fully healed. So sometimes you can't repair the extensors, you just have to salvage. So final thought. Extensor loss is the most difficult revision problem I face. Give me an infected re-revision any day over extensor loss, because extensor loss will significantly affect the outcome and function for the patient. At all costs, protect the extensors, and if you're doing a complex revision or a complex primary, spare a thought for tibial crest osteotomies. It's a benign procedure that will keep your extensors intact. Thank you.